The broadcast is now starting. All attendees are in listen-only mode.
Welcome and thank you for attending our webinar, Revolutionizing Healthcare Management Using Care Coordination and Analytics. My name is Melanie Bean, Vice President of Growth and Commercialization with GSI Health, and it is my pleasure to guide us through our discussion today. Let's take a brief moment to review a few important items. As attendees, we want to make sure that you understand that your lines are muted for the webinar. If you would enter your questions into the chat area as designated in the diagram, and then your questions will be addressed based on the time remaining at the end of the webinar. Questions not responded to, please request a follow-up in your entry into the chat section for GSI Health to contact you directly. All attendees will receive a link to the webinar recording, an overview document, and a list of our presenters' upcoming speaking engagements by December the 1st. Now I'd like to introduce you to our presenters for the day. It is my honor to present Lindsay Jubelt and Lee Jones. I am confident that the information that they will be sharing today will be thought-provoking as well as educational. Our first speaker today is Lindsay Jubelt. She is a medical director of population health at Mount Sinai Health System, where she leads clinical program redesign across the health system. In her work, she aims to strengthen the health system's role as a learning laboratory to improve the quality and value of care provided to the patients. Dr. Jubelt is also an assistant professor of medicine in the Icahn School of Medicine and practicing general internist in a team-based primary practice at Mount Sinai Hospital. Dr. Jubelt received her BA from the University of Pennsylvania, her MD from Stony Brook University. She completed her internal medicine residency at the Massachusetts General Hospital, followed by training in health services research via the Robert Wood Johnson Clinical Scholars Program at the University of Pennsylvania. As you can see, it was important to have Lindsay as part of this discussion today. Our final speaker is Lee Jones, who is the Chief Executive Officer of GSI Health, a healthcare technology and solution company that provides integrated care coordination and analytics enabling whole person care for complex populations. GSI Health is on the front forth of population health management solution and has helped pioneer working models for effective collaboration in community-based care delivery. Lee is a recognized expert in healthcare information exchange and health IT more broadly, performing strategy development, business analysis, technical architecture, and solution design. He has assisted several states in the development of architectures and operational models for healthcare information exchange. Lee holds a master's in science and engineering in the management of technology jointly from the Wharton School and the School of Engineering and Applied Science at the University of Pennsylvania, and a BS in computer science from Carnegie Mellon University. Lee has also joined in a variety of industry initiatives such as the Federal IT Standards Committee, the National Longitudinal Care Coordination effort supporting HL7's CDA R2 standard, Transport Standards for Secure Communication, which are the direct protocols, Healthcare Information Technology Standards Panel, and also participated under Dr. David Brailer, the original National Coordinator for Health Information Technology and non-presidential appointee. Additionally, Lee was an inaugural member of the ONC and also supported Health Architecture Initiative and Consolidated Health Informatics Initiative as well. Again, as you can see, the two of these speakers today will be able to provide us with a wealth of information and to be able to provide a thought-provoking hour and a half of information for you to digest and then to ask questions at the end. Following the presentation, we'll be moving into questions and answers. Please provide your questions through the chat function of the webinar. And again, thank you for joining us today. I will now turn this over to Lindsay. And Lindsay, again, thank you so much for being with us.
Melanie, thank you very much for the wonderful introduction. I'm thrilled to be part of this webinar today and share this information with all of you. So I'm going to be talking to the group today about data-driven healthcare. And our objectives are, as we think about financial risk and healthcare reform transitioning to health systems, how we understand risk stratification, describe what it means to reduce unwanted variation in care, and discover ways to shift care from higher cost to lower cost settings. So just to start to give you a little bit of overview of where I'm coming from, so I work in the Mount Sinai Health System. This is a 7-hospital system in the New York metro area that has hospitals in a number of boroughs and then health centers, practices, and ambulatory surgery centers and urgent care centers across the boroughs and even beyond the New York area. So as Mount Sinai has started this journey into thinking about managing high-risk patients and care management, this is in the context of shift happening nationally in healthcare. So we're moving away from fee-for-service toward episode-based payment and toward capitation. So moving from the left side of this graph toward the right side of the graph. And what is happening there is that the financial risk, which was traditionally held by payers, is shifting over to providers. Mount Sinai has not just started this journey, it's taken an aggressive leap forward. So this summer, these ads, we took out full-page ads in the New York Times and the Wall Street Journal, and we are very proud of these ads. What they say is that if our beds are filled, we have failed. We are committed to this new population health initiative, moving away from our traditional business line of driving up volume to increase the revenue in our hospital toward what we feel like is more aligned with improving outcomes for our patients, keeping patients healthy and well and out of the hospital so that if they're coming into the hospital, that means we're not doing a good enough job. So we're very serious about moving into this space, and as we do so, we're learning a lot of lessons along the way. So one of the first areas we started with was to target our high-cost patients. So as we take on financial risk, we start thinking about how to manage those high-cost patients. And I think it's important here to start just to clear up some commonly used terms when we talk about stratifying patients. Commonly used terms are high cost, high risk, and high utilizers, and these are often used interchangeably. And while there certainly is a lot of overlap of these 3 terms, they are distinct, and it's important to differentiate them. So high-cost patients are exactly what it says. It's the patients with the highest healthcare expenditures in a defined population. High risk is a bit more vague. When you say risk, you're saying risk for having some future outcome or event. And so it's important to define what risk means, because as people develop prediction models to predict certain risk, the model corresponds to the outcome that you're trying to predict. So if you develop a risk prediction model for readmission, that may not apply for trying to predict risk for admission or risk for future healthcare expenditures. And so high risk is a term we commonly use, but you should be very careful about how it's used and make sure you unpack it and understand it if you're working with others. And then last are high utilizers. So these are commonly defined based on utilization of acute care, so a certain number of acute hospitalizations in a year or ED visits in a year. When we first started trying to manage our high-cost patients, we first looked at the top 2.5%, and this diagram is commonly seen where you look at this pyramid where the top X%, top 2.5, top 5% account for a large bulk of your spending. So if we look at our top 2.5%, they account for 60% of our costs. So we started first here by trying to identify who were our top 2.5% with the idea if we could better manage these patients, we could really lower the costs overall of our entire population. So we learned some interesting things as we started trying to manage this population. One was that when we looked at a group of patients that we had not yet started care managing for, we saw some interesting patterns. And so what I've shown here on the left is a group of patients that were in our top 1.25% of our high-cost patients, and then the panel on the right is our top, so left is 1.25%, the right is 2.5%. And these patients account for a large percentage of our costs. When we watched their costs from year 1 to year 2, what we saw was that they fell remarkably. And this was, we had provided no intervention to these patients, no care management programs, doing absolutely nothing. Our high-cost patients fell more than 50% from year 1 to year 2. This was really a dramatic realization for our healthcare system. What we realized is that our high-cost patients today are not necessarily our high-cost patients tomorrow. And this becomes very tricky when you start to think about, well, who are the right people to put into care, care management programs? Who are the right people to target? We were not the only people to have this realization recently. This past spring in Health Affairs, the group out of Denver, Colorado, looked at their high utilizer population. So they defined their high utilizers here as 3 or more hospitalizations in a 12-month period, or 2 or more hospitalizations plus a diagnosis of serious mental illness. And when they look at the cost of their high utilizers, they were very similar to the cost we saw in this patient population that we looked at. They were about $113,000 in the first year, and by the time they'd gone to the next year, they'd fallen to $63,000, and then the following year, $47,000. And so the same sort of regression to the mean effects. They saw this fall in cost from one year to the next. This is another figure that comes out of their paper. And what it shows is what happens to those patients that they were targeting, those high utilizers. So that bar there on the left shows the 100% sample of all of the patients they included early on that met this high utilizer criteria. The orange part of that bar represents people who died during the study. So during that year, a small percentage of people died. The biggest part of that bar, the blue part of the bar, is patients who met the high utilizer criteria but then lost that status. They no longer met the high utilizer criteria. Yellow represents folks who lost and then regained that status, so they were high utilizers, they became non-high utilizers, and then they're high utilizers again. And that very small bit at the bottom, that pink, are folks who remained high utilizers month after month after month after month. So gosh, what a substantially smaller percent of patients are really staying high utilizers. And these are the folks that we think that we want to target with care management. Wow, like what a small percent of that 100% sample. So this interesting thing when you think about care coordination is that, I think historically we really just haven't had enough data to do it well. And we're starting to get to a point where we can. But when folks back in 2009 looked at some of the 15 randomized controlled trials that had looked at care management programs, out of 15 of these programs, and these programs were ones that ran randomized controlled trials, so patients were randomly assigned to usual care or to care management. Of all of these programs, not a single program achieved cost savings. Some of them achieved some improvements in quality measures, but not a single one of these programs achieved cost savings. And so you have to question why, and maybe it comes back to this issue that historically we haven't targeted the right patients. So there is an opportunity to lower costs in care management, but again, it means finding the right people to target. And so when you think about patients who are high cost today, there's different trajectories they can go. So tomorrow or next year, a portion of those high cost patients will continue to be high cost, and a portion will fall and regress to the mean, like we saw in many of our populations, will become lower cost. If you're a high cost patient that stays high cost, there's a huge opportunity to impact savings here. We know these are the folks that spend a lot of money. You want to match it to the appropriate intervention level that's going to make a difference. So you want to match it to a high intervention. That cost, therefore, of the intervention is going to be high, but you have an opportunity to lower cost. And so if your intervention is lower cost than the opportunity to savings, which typically it is in this very high cost patient population, your ROI can be positive here. If you match up this high cost group with a low intensity intervention that is unlikely to be successful, your cost of your intervention is low, but you really are not going to have much impact on that population. And so your ROI there is in fact maybe negative because you may not impact cost and you still bear the cost of your program. For those patients that go from high cost to low cost, you have very little opportunity to impact savings because they've already become lower cost. And so this is where we really don't want to happen. We don't want to target the patients that are high cost today but are going to be low cost tomorrow and match them up with a high intensity intervention with high cost, because you're not going to have any effect because they've already become lower cost, and you're going to have a strongly negative return on investment because now you're spending a lot of money on an intervention for folks that don't need it. If you were to match them up with a low intensity intervention, it's a low cost intervention, you probably have no impact and you may have a weekly negative or breakout even ROI. So if I walk us through the low cost folks, these patients in fact will become high cost next year, and some of them will stay low cost. And if we can match the high cost patients up again with a high intensity intervention, we can lower costs and we can have a positive ROI in this group. If we match them up with a low intensity intervention, it's probably not going to have an impact, and then we're not going to have any savings, and we're just going to be paying for the cost of our program. If we match our low cost folks who stay low cost up, we have very little opportunity to have savings here. So regardless of whether we impact them with a high intensity intervention or low intensity intervention, our ROI here is going to be negative. So the real opportunities are to figure out, okay, of our high cost patients, who's going to stay high cost, and of our low cost patients, who's going to become high cost, and matching them up with the right intensity of intervention. That's what we need to get to. So what we're realizing is that a lot of our traditional data sources that we've used historically are alone are insufficient. And so we know that there are a lot of psychosocial drivers of healthcare that predict utilization that haven't traditionally been captured in our healthcare data. And these are things we need to really start thinking about. How do we capture them? What are the right tools to capture them? And how do we integrate them into our IT systems? And once we have that information, what do we do with it? We really need to crack that nut. There was a group up at Mass General that started thinking about this, and what they did was they took some of the best commercial risk predictor tools, and that's the dark circle there on the left, and they looked at the positive predictive value of being able to predict acute care utilization using those claims-based prediction tools. And what they found was that they were able to predict utilization about 29% of the time. They then took their primary care doctors and had their primary care doctors examine their panel of patients, and they said, hey, you doctors know your patients fairly well. Of your patients, who do you think is high risk for having, an acute care utilization? Who do you think is going to be high cost? And so the doctors ranked their patients. And what they found was that when physicians define complexity, the positive predictive value of that was about 31%. So about the same as the claims prediction tool, maybe a little bit better. But what is most interesting is when you combine these two scores. And so when you combine the two, they get even more powerful. And so what this indicates is that they're picking up different things. And what we really need to start thinking about is combining, our IT engines and our data sources and our big data with humans who can pick up other sources of data that maybe we haven't yet figured out how to capture in our traditional data sources. There are other important areas of data that we also want to start thinking about that we know can predict both utilization as well as how well we're doing in a care management program. Often as we match people up to care management, we hope we're picking the right group, but gosh, it'd be nice to know next week or in a month how we're impacting them rather than having to wait years down the line to be able to track utilization. And so there are a few different measures that can be used here. One is the measure of health confidence. Also patient experience, and last, patient activation measure. So all of these are great ways of tracking, am I making a difference on my patients that I'm care managing, and also to be able to, from a baseline status and looking at a population, who's going to be high risk. So patients who already think are high risk based on clinical or claims data and report poor health confidence or poor patient activation, those are definitely patients who are not going to fare well in the future and are going to be that high cost group or high risk group who will continue to stay high risk. So as I talked about a number of different data sources that we want to start building and integrating into our data warehouses. And so information that providers elicit, patients, or care managers, claims data, psychosocial data, patient-reported data, all of that we want to put into our data warehouse and start doing analyses in. And I think we're all just starting to learn how to figure this out. We're building these systems here at Mount Sinai in terms of how to best integrate all of this data into one place. The other thing that we're learning, as I told you, when we first started thinking about high-cost patients, we targeted just those, and now we're starting to think about, of that high-cost group, who are the right people to target? And so what we're realizing is that traditional patient stratification along that pyramid is not effective. We need to think about new ways. And so the one major issue is that there's different types of high-cost patients. And then as I showed you in those graphs, a large percent of those high-cost and high-utilizer patients are transitory. And investing in the wrong patients, folks who were high utilizers 3 months ago, they may be the wrong targets. We need to figure out who are the right targets. So how do we find the right patients? So one is that we can combine these data sources. The second is that we can segment the patient population, and this is what I'm going to share with you next. And then the third is to set up surveillance systems to recognize and respond to important and timely data. So thinking about segmenting the patient population, as we've started trying to break out of that traditional pyramid, we've realized that there are different types of high-cost patients. So if you do what's called a cluster analysis and you look at two different vectors of where patients spend money, so on hospital care and outpatient care, you can see each point here represents a patient. Patients fall in different places along this graph, but you can see clusters starting to emerge. And so I'll circle those clusters and I'm going to label them. So this cluster down here has very high outpatient costs, but very low hospital costs. Down here on the far left, they have low costs, both hospital costs and low outpatient costs. And these are your young and healthy patients. Up at the top left, these are patients who have high hospital costs and low outpatient costs. So examples of this may be traumatic events. If someone gets hit by a bus, they're in the hospital for an extended period of time. It may be a very expensive hospitalization, but they're not going to have ongoing needs as a patient. But also in this group, maybe you're psychosocially complex. So folks that are frequent flyers of your acute care, your EDs and your hospitals, but don't engage in outpatient care because of either substance abuse or mental health issues or unstable housing that are preventing them from engaging in outpatient care. Up here in your top right, you have a combination of your end-of-life patients and then your complex chronic disease. So your folks with multiple comorbidities who are high utilizers of both hospital care and outpatient care. So that's really the group where you want to start thinking about care management, because that's the group where you can have an impact, where you can lower acute hospitalizations, where you can anticipate that they're going to have more of them, where you can put a program in place to try to lower them. It's very different than your traumatic events where it's one and done. They're not going to have another event for you to influence, or these folks with high outpatient care costs, such as expensive cancers or autoimmune diseases that are predominantly treated in an outpatient setting. A care management program is not going to be very effective at lowering costs for those patients. So this is what the direction that we've started to head. And the marketing industry has done this for a long time for looking at consumer behavior and understanding all of us as consumers and our patterns. And we're a little bit slower coming to this in healthcare. But I think this is so helpful as you start to break down your higher cost patients and get away from that pyramid to understand that there are different types of high cost patients. And only some of those clusters do you want to match with care management programs. So then the last piece that I want to talk about is setting up a surveillance system to recognize and respond to important timely data. So we know that some of these low-cost patients are going to become high-cost patients, and some of our high-cost patients are going to stay high-cost. Well, gosh, when you have a hospitalization or an acute event that is pretty bad, and you come with a number of comorbidities, that's an indication right there that you are a high-risk patient going forward for the next period of time. We know that may not stay forever. We know a high-cost patient 1 year may not be your high-cost patient next year. But if you're hospitalized, we want to know about it right now because you're going to be vulnerable for the next 30, 60, 90 days. And so we need to build surveillance systems to recognize important timely events such as those where we can really make an impact. So hospitalization is a great example, but I have other examples as well. And so what we've done in our EPIC electronic health record is we've built in a flag to indicate a patient who's already been identified as high risk, and we identify this by showing that they're in active care management. And so when they get hospitalized, notification goes out to their care manager, to their PCP, and to their entire care team to say, hey, this patient's been hospitalized. And that team taking care of them on the hospital can see that they're in active care management, and that's a signal to say that they're high risk. And you can click on that button to be able to find out who the care manager is and be able to contact them. And so this is a way to have our surveillance systems looking over our patients to say, as soon as an acute event happens, the care coordination team needs to know about it. So I'm going to buzz through this. And then I want to talk about a second example of being able to predict important timely events that's on a slightly different time course. So trying to identify hospitalizations when they happen is, right then and there. Second surveillance system we've built is our kidney disease surveillance system. So kidney disease patients and patients on dialysis are one of the most expensive populations that there is. What we know is that there is a growing burden of chronic kidney disease across the country. And many patients have chronic kidney disease, but a smaller proportion of them go on to requiring dialysis and becoming end-stage renal disease. And the most vulnerable period for these patients, both in terms of morbidity and mortality, but also in terms of cost, is that couple months before transitioning to end-stage renal disease and then a couple of months after making that transition. When you look at nationally what happens to these patients, about 40% of the patients who have chronic kidney disease crash into dialysis. What that means is that they end up in the emergency room requiring dialysis emergently rather than being diagnosed ahead of time, seeing a doctor, a nephrologist, and planning ahead for kidney replacement therapy. At Mount Sinai, when we started this, our numbers were substantially worse. We had 60% of our patients crashing into dialysis. And so what we've done is built this surveillance system across our electronic health record, where we're pulling in lab data and other data to be able to identify, first, if you have chronic kidney disease, and second, your risk of progressing onto end-stage renal. And so we have 70,000 patients in our registry, and across all of them, we can say what stage of kidney disease are you and how likely are you to progress onto end-stage renal disease. So many, many months ahead of time, we are flagging those patients and pulling them into a program and a care pathway to be able to shepherd them through the transition from chronic kidney disease to end-stage renal disease. And so this is, again, another example of being able to develop surveillance systems to identify these timely, important moments to be able to intervene on them. And by doing so, we are going to be able to prepare our patients to get ready for dialysis and have that sharp peak there that you see. We are smoothing that out to both lower costs, but also lower our morbidity and mortality associated with making the transition from CKD to ESRD. So we've talked a lot about care coordination and how to identify high-risk patients and prevent hospitalizations and other acute events that might happen. It's important to understand that just targeting high-risk patients alone is unlikely to solve healthcare's high-cost program. So this was an analysis done in JAMA by Ashish Jha and his group. And what they did was they looked at the different conditions of inpatient hospitalizations amongst persistently high-cost patients. So that cohort of patients that were high-cost and stay high-cost. When they looked at the percent of hospitalizations that were preventable, about 10.4% of these hospitalizations were preventable, and close to 90% were not preventable. And so you can see here, even amongst our highest risk cohort, who we would hope we could care manage and keep them out of the hospital, the bulk of these hospitalizations may not be preventable. And so we have to think about other solutions if we are going to try to improve our healthcare systems to improve patient care, health outcomes, and to lower total cost of care beyond just care management. So this is where Mount Sinai has moved, in addition to our care management program, to start to think about our system overall and how do we reduce system inefficiencies and low-value care. When you think about variation in spending across the country, the Dartmouth Institute folks are the national experts on this, and if you're not familiar with them or their website, definitely Google them and go to their website. They have some beautiful maps looking at variation in care patterns. So this map is looking at variation in Medicare spending across the country, and what it shows, and this map has already been adjusted for local wage prices, age, sex, and race, so adjusted for a number of demographics. What it shows is that your average Medicare patient in San Francisco costs about $7,780. In Manhattan, where I am, they're about $10,306, and in Monroe, Louisiana, $13,000. So wide variation in spending in Medicare. And after adjusting for these factors, it raises some questions. And so many people have argued that reducing low-value care can save a substantial amount of money from our healthcare systems, and that 1/3 of healthcare expenditures are estimated to be inappropriate or wasteful, and that total amount of money is estimated to be about $750 billion. I have a typo there on that slide. That's actually billion. So there is potential for substantial savings if care could be improved. So there are some acceptable sources of variation. One is certain aspects of health status of the population or demographics. Again, those Dartmouth Atlas slides attempted to control for a lot of those things, and what you're left with are unacceptable sources of variation. such as system inefficiencies, the overuse of low-value services, and service duplication. So these are really areas that as we're thinking about taking on financial risk for populations and trying to lower total cost of care and improve efficiency, that we're starting to examine. And so variation in spending is not just a national problem, it also happens locally. So even within our own healthcare system, what I'm showing here is variation in care for routine low back pain at Mount Sinai. And I've listed here a number of our practices, their volume of patients that they see for low back pain, their referral rates, radiology orders, and opioid prescriptions. And so when we looked at this, we were really floored at the difference in practice patterns for a very common condition. And the variation didn't just end here. Even within, when we looked at where the different practices were referring people, there was also substantial variation. So you can see here that a lot of folks refer to physical therapy, but some don't at all. And you can see pain management, orthopedics, rheumatology, and physiatry. So just wide variation in how we're practicing medicine and delivering care for patients with a common problem of low back pain. What we started to do in response to this is to design standardized treatments across our entire system through care pathways. And so we leverage evidence-based medicine and clinical guidelines, and a lot of our experts, both our physicians as well as our multidisciplinary teams, physical therapists, care managers, and nurses to inform how we built out this pathway. And these pathways we started on paper and iterated again and again and got feedback, and now we're building them into our electronic health record. Once they're in our electronic health record, they become an order set, where rather than a physician having to order each different referral and medication and other different services for someone with low back pain, they can just click a button and the entire order set comes up for them. And so they're not beholden to have to order this order set, but we do encourage them, and because we've gotten buy-in in the process, many of them are very happy to do so, as this was a product that they helped develop. But then we've made it easy on the back end in the electronic health record that it's just clicking one button rather than the 10 that you might have to click in order to order all of the different services for someone with low back pain. One of the national programs that's pushing health systems in this direction is bundled payment. And so bundled payment is a new way of paying for healthcare where it combines for the Model 2 version of the program that many folks are participating in, it combines the acute care hospitalization with the post-acute care. So with this program, it has helped us not just build out pathways for the acute care setting, but also build out those pathways into the recovery period for the patient. We think this is a wonderful thing. It aligns our incentives with what is important to the patient, because from the patient standpoint, if they're coming in for a procedure, say a total joint replacement, their episode of care from their perspective doesn't start and end in the hospital. It starts before coming to the hospital. It has the peak in the hospitalization period, but then it extends through the recovery at home. And so by having these financial arrangements with the bundled payment program where we're financially on the hook for this, it aligns our incentives to build out our care pathways beyond even the acute care hospitalization. And so that's what we're working on now. As we've realized the value of looking at variation across our hospital and examining different care patterns, we're realizing that this is a great opportunity for our care managers to get involved. So our care coordinators or care management program is very involved in these high-risk patients and trying to identify those clusters of patients that we can really have an impact on. But they're also involved in looking at variation in care patterns across our hospitals. And they receive weekly reports about the care pathway uptake and adherence. They can identify members of the care team who are outliers and lead discussions with the clinical teams about barriers of adherence to these care pathways and how to facilitate standardization of care. And so we've found that our care managers or care coordinators are a wonderful addition to these teams, and this is a wonderful second function for them to fill, is to not just only manage our patients, but also to manage all of our care teams and our care pathways. So the lessons that we've learned in trying to reduce our system inefficiencies and improve the value of care that we provide is that we've built these care pathways that are informed by multidisciplinary teams, and I think that's so important to have it be influenced by multidisciplinary teams. Second is that our care management can play a critical role in supporting the standardization of care. And third, that by engaging in programs like the bundled payment that financially support high-value standardized care really pushes us to continue to do this work and gives us the financial benefit if we're successful. So the last thing that I'm going to talk about at Mount Sinai that we're working on is ways to, again, improve the outcomes for patients and lower total cost of care, is shifting care to lower cost settings. So back in 1984, CMS introduced the Diagnosis-Related Group Payment System, the DRG system, where hospitals started to be paid a lump sum for a hospitalization, where they had been historically paid fee-for-service. And by getting this lump sum, it caused hospitals to think about being more efficient and better stewards of their resources than they had been historically. When this program went in place, you see some interesting changes. One is that length of stay, hospitals start paying attention to, and so you can see the trickle down in length of stay over time once the DRG system is put in place. The second change that you see is a remarkable growth in post-acute care spending. So this graph shows the growth up until 1997, but post-acute care spending has more than doubled over the past decade alone, and it's now a $40 billion industry. So when you look at variation in Medicare spending across the country, that's the panel on the left, and then you look at the variation in post-acute care spending, they look awfully similar, and that's because variation in post-acute care spending is actually the biggest driver for variation in Medicare spending. So there seems to be a lot of waste in post-acute care. Prior to my time at Mount Sinai, I had partnered with NYU on their bundled payment program, and one of the nice things about bundled payment is it really puts attention on post-acute care for the first time where there had not been historically. And when NYU started the program, their discharge rates to facilities was so high, much higher than national average, close to 80%. And while some patients benefit from going to post-acute facilities, many patients may even do better at home, and this is an area that really has been overlooked historically. And so we dramatically changed our discharge rates from facility to home, and our physicians were really worried that when we did this, what we were going to see is an increase in readmission rates. And what we saw, in fact, was the opposite. So in cardiac valve, we saw no change in readmission rates. And for our joint replacement patients, with this decline in referral to facilities, we actually saw an improvement in readmission rates. And for our patient satisfaction and measures of functional outcomes, they did a lot better when they went home rather than going to facility. Not a surprise, the patients are a lot happier if they're able to go home, but I think this is incredibly reassuring to see that if you do shift patterns of care from higher cost facility-based care to lower cost home settings, that your quality measures and outcomes look better as well. A similar program we're engaged with here at Mount Sinai is called the MAC program, the Mobile Acute Care Team, and this was a New York Times article that profiled one of our doctors engaged in the program, Dr. Cameron Hernandez. And what this program does is that it takes patients who are eligible for an acute care hospitalization, so folks who show up in our emergency room and need to be hospitalized, and rather than hospitalizing them in our hospital, our mobile acute care team will provide hospital level care for that patient at home. And so we can deliver a hospital bed, IV therapy, medications, nursing services, and a physician that will come and deliver hospital level care for you at home. This is completely revolutionizing how we think about delivering care and where we think we can deliver care. When we first started it, a lot of the vendors that we worked with, our IV therapy group, our pharmacy, just said, you know, there's no way we can get these things delivered to you the same day. And we said, you know what, we've got to do it. We're providing hospital level care. You can't wait for antibiotics. And so they've really worked hard to partner with us, and we've been successful together in being able to get these services to patients the day of. So you go from the ED to home and you get hospital level care immediately. And so this is a wonderful example of ways that we can transform our healthcare system to be able to deliver lower cost care, yet that is still excellent quality. So as we think about doing more of this sort of work, transitioning care to lower cost settings, so out of our traditional hospitals, out of our traditional post-acute care facilities, it's also important to start thinking about engaging patients overall. As we all take on more financial risk for patients, we know that patient engagement is such a key factor of success. So when you look at how the hours break down in a year, and you look at the distribution of where patients spend their time, that very small circle on the right represents the hours that they spend in medical care in a hospital or in a physician practice. The vast majority of hours patients are spending outside of hospital care. And so what that represents is a huge opportunity for us to think about revolutionary ways for us to engage patients when they're not within the confines of our institutions. And if we can do better at engaging patients in these settings, we'll do a lot better for improving our triple aim, improving our patient experience, improving health outcomes, and lowering our total cost of care. So I just want to summarize a lot of what I've shared with you all today. And so the first we started talking about, thinking about taking on risk for patients and trying to improve the value of care. So improving health outcomes, patient experience, and lower total costs. Start thinking about your risk stratification. And to be more successful at this than we have historically, we need to start combining different data sources. Combining our clinical data, our claims data, our physician gestalt, our patient-reported measures into a single data storage. That we want to segment our population, not just into high cost and low cost, because we know that as soon as we segment into high cost, our high cost patients today are not our high cost patients tomorrow. We want to cluster this population into groups with common traits, and identify those traits that we think are going to remain high cost, and traits that we think we can really have an impact on, that we have programs that we know are going to work. And then third, setting up surveillance systems to recognize and important timely data. So being able to recognize to a hospitalization, or being able to identify someone with chronic kidney disease that in the next few months is going to progress to end-stage renal, and being able to plan ahead of time to get them into the care to improve their outcomes and lower total cost. We then talked about reducing unwanted variation in care, so recognizing that just targeting your high-risk patients alone is not going to be the solution. So how do you look at your system overall? You need to build care pathways informed by multidisciplinary teams, employ your care managers to ensure adoption and support of standardization of care, and then engage programs that financially support making these transitions towards high-value standardized care. And then last, coming up with creative ways that we can shift care to lower cost settings. So revolutionary ways to redesign our healthcare settings to be more patient-centered and providing care for patients even when they're not in the confines of our institutions, and really thinking about patient engagement. So with that, I'm going to say thank you, and I so appreciate this time to share this information with you all. And I'm going to transition over to Lee to take over the presentation from here.
Thanks very much, Dr. Jubel. I appreciate you sharing with us today. It was a very exciting presentation. It's not often that we see people who have been able to actually be doing this long enough to have results that are shareable in the way that you have. So thank you for that. So I'm going to talk a little bit about melding care coordination and analytics. And one of the reasons that we put these webinars on is because we believe that the entire industry is really experiencing a renaissance of sorts, where everyone is trying to improve care, but there are certain stars that have aligned with public and private payers coming to be on the same page to incentivize different kinds of value-based care models and community-based care models. And we felt that what Mount Sinai is doing is really a great microcosm to start to explore what's working and what isn't, and what is a reasonable level of progress given given the amount of time that this has really been in the forefront of the industry. So I'm going to take a little bit of a step back from the specific example of where these things have been executed, and talk a little bit about what we're seeing in our customer base as they try to form these various care models that rely upon care coordination and collaboration. So in case you are not familiar with GSI Health, we are a software as a service provider that has a population health management platform that enables various provider organizations to collaborate across a community, across enterprises, across organizations in the treatment of their common patients. And typically, Our customers are managing specialized populations such as Medicare or Medicaid and trying to achieve various outcomes that they're incented to do. Our software helps them to organize the patient population, to organize their virtual care teams, and to provide a collaborative environment where they can do joint care planning as well as manage the analytics that will tell them how well their programs are doing. And so this sort of shapes our perspective. And one thing that we've come to believe, and I'm going to spend the balance of my presentation talking about, is that the two key components to what's commonly referred to as population health management are care coordination activities and the analytics that evaluate them. And we further believe that those two things are so intricately tied together in the successful programs that it really merits some expounding upon, so that as these programs start to get off the ground across the country, we can help people take some initial first steps that are going to pay off in dividends down the line. And in particular, our contention is that having a close coupling of care coordination and analytics in the same platform will provide benefits that will be evident as you move into these kinds of new care models. So to think about that, let's take our minds back to a time when you could get a reminder to call someone and then you wanted to actually give them a call, and that actually required two different pieces of technology. You might look at your personal digital assistant, PDA, and see that there was a reminder, and then after getting that reminder, you pull out your cell phone and you try to find the person that you were reminded to call inside of your cell phone, which is an entirely different database, entirely different device, and then you would actually make the call. And so when we think about that entire transaction through the lens of today, it seems pretty archaic and ridiculous. And now everyone would say it's obvious that having one platform to perform those two symbiotic activities is the way to go, and it's the superior solution. Well, when we talk about population health management, there are two activities that are very close together, but unfortunately, the population health management tool sets that are arising is starting to create a divide between them, namely targeted analytic platforms and care coordination platforms. And so we believe that the same kinds of synergies that you would see in smartphones can be applied here in healthcare. And so when you keep those different activities separated, you need to have someone who is observing the care coordination activities. And then whatever they observe, they have to extract the data and information out of that activity and somehow get it into the analytic engine that they're using. And then once having run those analytics and gained some insights, somehow infuse those insights back into the care coordination activities. And so having this person in the middle, or organization in the middle, and different sources of data, different needs when it comes to making the transitions between them, starts to add inefficiencies into a process that is already plagued with a number of difficulties just inherently. But you might be saying, we're talking about, in these different care models, reshaping all of healthcare delivery, and this seems like a minor detail. Why would we spend any time at all thinking about it? Well, it's because as we start to go forward and get more mature, every fold that you make to this new piece of paper that we're putting down as a new care model matters. And we don't want to end up with some unintended consequence because we made some initial bad steps. And so I want to just look at how this care delivery model is being reshaped and moving from patient care or care of individual patients on a one-up basis to population health management. They both involve the point of care and actually delivering care to a particular patient. And in fact, they also involve the same set of activities. You have to decide what you're going to do in the delivery of care for that patient. You have to decide who you're going to deliver that care to, or in other words, what population or set of patients is this kind of care I'm prepared to deliver appropriate for. And you have to determine who is it that's going to select that set of things, both the protocols that you're going to use for delivering care as well as the target populations that you're going to manage. And after you made those decisions, someone has to carry it out, and then you have to get some information out of that process so that you can gain insight into what went well, and then you can iterate and improve. So this is just a sampling of the dimensions that are involved in population health management and delivering individual patient care. And we want to look at how today's new set of care delivery models are expanding what was the point of care delivery of therapies, et cetera, to individual patients in order to accommodate populations now. So we'll look at each dimension in turn, starting first with what is it that you want to do. In the individual case of providing care to a patient, there is the provider who is the expert and knows what to do, and it's his or her experience or that organization's experience that allows it to happen. There may be organizational best practices that influence that. And there may be programs that are now starting to emerge, such as Health Home Program in New York State, for example, that are incentivizing particular activities and may go as far as to specify certain activities that should be done in the treatment of particular disease states, et cetera. And then there's always the evidence-based medicine and the literature that talks about how various diseases should be managed and what the best practices have been found. What we're seeing as these emergent value-based and community-based models are emerging is that there's a set of community-wide best practices that really draw from all of those different sources that I've already mentioned, but also start to bring into account the operational details that are involved in collaborating across a community and outside of any one individual organization umbrella. And so those care activities for these models are starting to be codified at this community best practices or protocol level. We saw Dr. Jubel talk about the standardization of those different kinds of activities into care pathways, and we think that organizations are doing that and communities are starting to do that as well, trying to be able to operationalize the delivery of care and make it easier for people to follow standardized protocols. When we look at who should be receiving this kind of attention, these extraordinary interventions, et cetera, again, you could do it for every patient that comes across the threshold that is encountered in the delivery of care. But more often, there are targeted populations of patients. For example, Medicaid patients may be the target population. And then a further refinement on that might be that there are particular patients that you're trying to achieve or avoid a particular outcome for, such as readmissions. And those might be a subsection of a targeted population. And we're seeing that what's really becoming desirable as these new care models evolve is not just the population or the outcome that further refines that population, but really understanding what patients are impactable. If I'm going to expend this extra energy, how can I find the patients that I can really make a difference for? And this is a non-trivial task. As Dr. Jubel talked about, there is this declining set of high utilizers who come in and they're actually high utilizers for a time, but then they sort of fall off of the grid. That would seem to imply that if you're going to institute a program that is trying to impact the cost or the utilization of this patient group, you have to catch them when you can. And so there's a particular window for interventions if you're unable to accurately predict who's going to be more persistent, where you can actually apply your therapies and your interventions so that you can make a difference. In fact, you may not be able to do it fast enough in the intervention window and have to really look to intercept them before they become high utilizers. I think that that's the target of a lot of analytics today, to try to make those kinds of predictions. And so figuring out who it is that you're going to actually expend your energies on is an important aspect of this population health management. So those two factors, what you're going to do and who you're going to do it to, are certainly key things, and people do them in a number of ways. But the next three axes are the ones that I particularly want to focus on as they start to involve the technology choices that you make to help you. So I want to look next at who determines what you should be doing and who those populations are, and then who actually carries it out, because I think that those are related to one another. So when we talk about who determines the course, again, when we're close to the point of care, it's typically the individual provider. There may be the enjoyment of some case management activities, whether provider case management or managed care organization case management activities. And then what we're starting to see now emerge in some of these collaborative care models is some sort of what I'll call a program office. So there may be a central convener who pulls together different organizations so that they can collaborate in the delivery of care. And in that centralized office, they will analyze that care and draw conclusions and insights that then propagate out as a care model. And that seems to be a popular way to sort of keep control of these new collaborative care models with lots of stakeholders. But they are subject to relay effects, which is similar to the diagram, the illustration I gave earlier, where this program office now has to be in the middle of what's going on, do the analysis in their back rooms, and somehow propagate that out into the broader network so that care can be impacted. And so while it certainly can and is working in various places, there are things about it that can be improved upon and optimized as the industry matures. Another area where we see that people are deferring the decision of what actually happens in their clinical model and their care model is to what I'll call the program sponsor. So a lot of these models are being incentivized through some sort of specialized program, whether it's from the government or from some other kind of payer. And those programs will specify a lot of detail about what's supposed to happen, what you're supposed to do, what patients you're supposed to do that with, et cetera. And lots of people are just defaulting to what those programs say as the way that they should go forward. But there's a misalignment of accountability and efficacy judgment with that approach, because those programs have different motivations and different set of criteria for making the decisions that they make. And so a number of programs are finding that the decisions and the rules and the guidelines that are being advocated by the program sponsors sometimes run counter to the efficient and effective way to deliver care. And so while again, this is not an uncommon way to fulfill this role, it's probably better served in a different area. In particular, the stakeholders who are going to comprise your care team in the community should be the ones who are able to collaborate and to help you decide who and what should be done. When we talk about who's actually carrying it out, obviously individual providers or case management from the provider or NCO side are the typical candidates who would implement these kinds of programs. But again, the emergence of the care team and the cross-disciplinary, cross-organizational care team that you find in a community in particular is now starting to become a dominant design. And that alignment that happens between the care teams when they're able to both make decisions about what the care models will be and to actually deliver that care allows them to have the perfect perch in order to have continuous improvement of their care models as well as to be effective going forward. And so aligning the users of the information with the analytics and the analysis of that information so that they can make appropriate decisions about what should be done, especially as these care models evolve and emerge, is critical, and we think is served well by having those two activities, i.e. the execution and the planning, close to one another and feeding so that you can have a seamless transfer of information between them. And then finally, when you deliver all of that care, it throws off a set of information. And some of that data needs to be able to support future insights so everyone can understand how to improve and go forward and have effective programs that are continually getting better and reaching the outcomes that they expect. When we talk about historically with individual patient care, it tended to be those sorts of insights would come from the local information that was available to the provider who was delivering the care, siloed clinical information, maybe in an isolated electronic health record or something like that. When people wanted to be broader about a patient's episode or set of episodes, claims data always was a desirable way to add breadth to a patient's history and longitudinal record. And then there are a number of efforts that even in this collaborative model where people are pulling from different sources, both claims and clinical, in a sort of a disjointed fashion from wherever they can grab the data and putting them together for this analysis of their care coordination activities. And then, of course, health information exchanges are a part of a lot of these infrastructures, which now will take on some of the normalization and harmonization tasks so that information at least can be gotten from a single source, either to rival the claims breadth with clinical data or to enjoin claims data with clinical data. But in particular, as these models arise and the rise of the care plan and the care team and the operational aspects of the care delivery model are starting to come to the fore, there's another class of data that we like to call coordination data that has to do with the issues and the interventions and the operational and tactical steps that are needed to be taken, both in the psychosocial and medical or home realms, that are not often captured in these other traditional data streams. And so this community coordination data now is taking on a prominence and is subject to analysis that can help the programs improve both operationally as well as clinically and medically. And I think that these factors about where the data comes from and how it's actually aggregated really become important. So Dr. Jabel talked about this model of feeding a data warehouse so that the data analysis can happen on top of it. That data warehouse is something that lots of organizations are implementing, but there are a lot of different challenges with trying to do that, especially across multiple participating organizations. Normalization across all the different sources is always a challenge. The timing and synchronization of data coming from different sources is a challenge. If you're trying to do analysis on clinical data that's coming through in a real-time basis, and then you're trying to merge that with data that comes from a reconciled claim stream that may be 3 or 6 months old, you may have some problems if your analytics is dependent upon both of those kinds of streams. Further, the depth and breadth of the feedback and insight that you're able to feed out of the analysis, going back to the point of care, has to be analyzed and paid attention to, because we want to provide the right kind of information so that care can actually improve. And I think that Mount Sinai really shows us a good example of how taking the data and information available allows you to be very proactive about your care model. And so Dr. Jubel pointed out that care managers are involved in all of those traditional care manager activities, as well as monitoring the adoption and adherence to their standardized care pathways. They receive weekly reports, and they take those reports and they work with the care teams and work with the organizations to make sure that they're constantly improving. And it's that kind of model with an active, analytical thinking care manager who is involved in both the delivery of care and the analysis of it that is one that we think is a recipe for success. And so when we look at trying to expand away from the traditional care delivery model that is focused on delivering the best possible care to a particular patient and expanding into a population health model, we see that the point of care model has the provider experience on what to do, the patients that come across the threshold as who is impacted, the individual provider is determining everything, and the individual provider carries it out and is the one and is relying upon the data that they capture in their sort of enclosed system. As we talk about moving into population health management, we want to expand beyond just the point of care model and try to join the community. And so we see that community best practices can enhance and supersede just the provider's experience. Targeted, impactable patient populations as opposed to the broad net of people who just come across a threshold are starting to come to the fore. Having community care teams that are able to make decisions about the care model itself and the populations that they serve, as well as delivering that care. And then finally, having the data that is thrown off from the care coordination activity in addition to the native medical and other kinds of care and therapy information is becoming all important. So we see that there's an expansion that happens, and it allows this population health management to build upon the good things and, about individual patient care, but also take a community viewpoint. And so 3 of these 5 dimensions are better served by the close coupling of analytics and care coordination. Having an alignment between the care teams who are actually doing the work and the ones who have to study the analytics, as well as using the data that is thrown off from that care coordination activity in the continual improvement, all speak to the need and desire to have those things really tightly coupled together. And so when we talk about unifying them under one platform, what is it that we're really saying? Well, having the analytics and the care coordination close together takes the person or organization out of the loop in terms of moving the information between those 2 macro activities. So the coordinated care environment brings not just data, but also users to the analytic realm, and then the analytics are able to provide timely insight back into the care coordination domain. So when we talk about things that become possible, point of care analytics, annotation of analytics with metadata that is not well captured in the data that feeds the analytics itself because it's in context, and even providing the care model configuration to the extent that there are some parameters in the care model that can be configured. Those things can be part and parcel with the other variables that go into an analytic model, such as what kinds of alerts are actually being spawned and how well are they being responded to, et cetera, et cetera. And the insight that can come back into the care coordination activity is almost unlimited. Cohorts and alerts, auto monitoring of patients and care teams, some of the things that Dr. Jubel talked about Mount Sinai participating in, having notifications of community-wide events, defining and recommending interventions that can directly be put into care plans in the care coordination setting, and then even calibrating the care model. And so, as with anything, there are always challenges. It's not all just a walk in the park. Certainly, data completeness in the coordination and analytic platform, whatever that happens to be, is always an issue. There's so much data, and there's so much data already in use in established systems and established analytic programs, et cetera. and people are pulling in data from multiple sources in order to create reports and do analysis, that it is a challenge to try to say all of that is now going to be resident in your care coordination platform. How do you present the analytics and the tools for analytics to people who are primarily care providers and care deliverers? They're not statisticians whose job it is to look at graphs and charts and tables and to make lots of sense of it. So you have to really make sure that you don't put a hurdle to them delivering the care by having things that aren't easily digestible. There's always the possibility of information overload and additional training and effort to try to change these care models, and then the change management of the process itself, which may seem like a lot and may seem intimidating, but now that everyone has made the decision to actually move down this path, when you take care in the steps that you take initially to put these programs together, by choosing the right tools, by being thoughtful about where you ultimately want to go and not just reactive to the programs that are right in front of you, the result can be very impressive. So in conclusion, we like to talk a lot about actionable information and that our analytics should provide us things that are actionable. I can do something about, I can do something with. Well, if we're going to talk about things being actionable, they have to be expressed in the language of action, which is the language that is being used by the people who are going to take the actions. And so having that language be part and parcel with the analytics itself, it has distinct advantages. Further, when you keep information close to the context in which it was captured, it becomes more useful and more understandable and recognizable rather than when it's disjointed and pulled from a number of intermediate sources that have done their own processing of data, and you have to try to stitch it back together. And then analytics and care management in the same platform, when done well, can be mutually reinforcing, and you'll find that the benefits of that will be akin to the benefits that smartphones brought us over PDAs and cell phones acting individually. So with that, I want to just thank you for your time, and we'll now move into a questions and answer period. And I'd like to invite Dr. Jubel to come back onto line off of mute if you are out there. Are you still there?
I am still here, yes. Thank you for checking.
Great. Well, thank you very much for your presentation. I think it was very enlightening to our audience. And I wanted to just start off the questions by asking some, I guess, rather mundane things. I know you gave a summary of Mount Sinai in the beginning with 7 hospitals and talked about where your treatment area is. Can you give any more details about the size of the network that is actually engaged in these kinds of care collaboration models? I know you had a number of owned practices and other things that you talked about in different parts of your presentation.
Yeah, absolutely. So we have about 6,000 physicians that are in our employed network, and then a number of additional, couple of additional 1,000 physicians that are in our voluntary group. So quite a large physician network. In terms of some of the contracts that we're engaged in, as we increasingly increase the amount of risk that we're taking on, we've been in the CMS ACO MSSP program now for over 2 years, and we are participating in the bundle payment arrangement as I spoke about, and we're participating in that for joints, valves, CABG, and stroke. And then we have some commercial savings arrangements, and then some full risk capitated arrangements with some payers. And so we're increasingly looking to partner, collaborate, and take on financial risk, because we really feel like by doing so, again, aligns our financial interest then with the mission of care that we want to deliver with keeping patients well and healthy. And so our goal by 2019 is to have 750,000 lives covered under risk-bearing arrangements, and as close to capitated as we can for most of those.
And so in the different set of results and observations that you talked about today, were those primarily within the Mount Sinai system proper, or were they crossing over into some of these more community-based and collaborative arrangements that you were just describing?
So the way that we think about our outcomes are really attributed at the patient level, and our patients are linked to our doctors. And so the patients, of course, seek care. New York is a complicated fabric of healthcare, and so many of these patients seek care at multiple different healthcare systems, not just ours. But the patients are attributed to us mostly based on primary care attribution models. And so the results that I'm showing are based on those patients that are attributed to us.
Okay, great. And I think that you mentioned this in the presentation, but one question that came from our audience was, what electronic health record system are you using? I think you mentioned Epic.
Right. So Mount Sinai went through a merger 2 years ago with a health system called Continuum, and that really was the beginning of our launch into population health, because Mount Sinai traditionally was a tertiary quaternary referral center with not a very strong primary care base. When we went through the merger with Continuum, that really fleshed out our portfolio and provided us with that primary care base to start moving into population health, which is wonderful. Our Mount Sinai system is on the Epic platform, and our Continuum system is had been on the Prism system, a GE platform, and we're transitioning it over to Epic and have done most of that work already, but we are still in transition.
Okay, great. And so you talked about the different surveillance systems that you were putting in place, and I think you gave an example that was in Epic that allowed you to sort of flag patients that had previously been hospitalized. Are the surveillance systems that you're talking about primarily EHR-based things, or are there other kinds of surveillance systems that you didn't discuss?
Yeah, so they're a combination of EHR and other IT tools. And so we have a data warehouse that collects data from our electronic health record system, our claims data, and other data sources. For the what I showed you as the banner in our Epic system, we're then able to feed a lot of that information back into Epic to notify the team that someone is in care management or has been hospitalized. And so some of our surveillance systems are in Epic and in our EHR, but a lot of them depend on multiple sources of data in our data warehouse and having the action and analysis happen there and feed back into the Epic system.
Okay. Another question that come from the audience is, what criteria were used initially to define the super utilizers?
So when we first started out, this is where I was saying we first started just targeting high-cost patients and realized that wasn't the right way to go because of this realization that there are different types of high-cost patients. We really wanted to focus on the ones that we could effectively care manage, so we switched over to high utilizers. And the definition that we're using there is 3 or more hospitalizations in the past year or 3 or more ED visits in the past 6 months.
Okay. And are there best practice guidelines to clustering, doing the clustering analysis that you showed, and the associated care pathways? Another question from the audience.
Yeah, it's a great question. So I think the cluster analysis it can be so valuable, and I think healthcare is really just starting to do this. I think the simple way of breaking it down, or a simple first pass, is the way that I showed the audience there, looking at patients based on hospital costs and then outpatient costs and examining your trends and your different clusters within those groups. But there are groups out there that are starting to get more sophisticated about this. So some examples are Sutter Health System in California has a huge grant and has been working with IBM Watson to develop more sophisticated segmentation models. The Camden Coalition, Jeffrey Brenner's group in New Jersey, is starting to do some of this, looking at their vectors or looking at some psychosocial factors. But I would suggest, and where we've started, is just the graph that I showed. Taking it, you can even take your claims data and start looking at your population, doing a cluster analysis based on hospital costs versus outpatient costs. And you'll want to find someone who has some basic statistic knowledge to know how to run a cluster analysis, but it's a fairly simple analysis to run in almost any software package. So you should be able to find someone who can help you with that. The second question was around care pathways. So care pathways, I think, have been around for a while, but are increasingly becoming more prevalent. And so if you're looking around a specific disease, a lot of disease or specialty societies have a lot of this information. And so you can find, say joint pathways, you can find those on the web or through specialty societies can help point you in that direction. So depending on the condition that you're focused on, I think this is really where tapping into your local experts can help you build and shape those. And I'm certainly happy to share some of the work that we've done on that as well.
Great. And when you did that kind of analysis and you sort of narrowed down from all the different kinds of high utilizers and found sort of a target group or group that was trying to weed out some of the noise, did you find that more specialized group had a higher continuance in that high utilizer category, or did they still fall off the way that those other graphs showed?
So this transitory nature of people seems to happen everywhere, but the trends that we're seeing once we did our cluster analysis is that falling off was not as significant. And so while you still had a portion of that population regressing to the mean, a larger portion of them remained high cost. And even some of those that their costs fell, their costs still remained high enough where we could care manage them and lower their costs and achieve savings, even taking into account the cost of our care management programs. And so by identifying that cohort, we found that was the right cohort for us to target where we could really make an impact on outcomes and on cost.
Okay. There are a few questions about some of the operational aspects of what's done. Is it typical for a healthcare organization to have a care manager as a full-time equivalent? Would they be the gatekeepers or rather the responsible party for managing the specific population appointed to them? So I guess it's about the role of the care manager.
Yeah, so I think this is the roles of care managers, care coordinators, care navigators, they have such different names. I think, again, this is a topic that is under active work everywhere, trying to figure out what is the right skill set, what is the right role, how much time. What we're trying to do as we look at our populations at risk is figure out a point person. And so for many of our lower risk or medium risk patients, it's often the primary care doctor. So empowering them, but also supporting them so that they can be a point person for that patient. For our higher risk patients that have multiple comorbidities, see multiple providers, and can easily fall through the cracks, these are the folks that we really want to match up with a care coordinator, but they're probably not going to be matched up with a care coordinator forever, because again, these people are transitory. Even if you have all of these chronic diseases, you may have a really bad year, but next year may be a good year. And so in being able to track and identify when a patient is doing well enough that they can graduate permanently or temporarily from care coordination so that you can better match up that very expensive high intensity intervention with the next person that needs it. So I think this comes back to those active surveillance, identifying timely moments where you can really have an impact, doing intense care management around that time period, teaching self-management, and then being able to track how you're doing so you know when you can start pulling away. And so this is where some of those patient-reported measures, so tracking patient rated self-confidence and patient activation can help you say, gosh, am I making an impact with this patient? Are they doing well enough that I can start scaling back the care management intervention and eventually pass them back into traditional care, knowing that they're kind of flagging them in the background as medium risk, that they may soon, may emerge again and need care management, but you provide that service as a temporary service. Care management, it's rare for a patient to need that permanently unless you're talking about end of life.
Okay. So I'm just watchful of the time. I think that we probably have to answer the remaining questions offline, but I did want to give you, Dr. Jubel, an opportunity to make any final comments or observations that you had before I turn it over to Melanie to close.
Absolutely. Well, I just want to thank GSI and Lee, thank you for inviting me to present to this group. It's been such a pleasure. I'm certainly happy to field questions offline, and I look forward to it. And I think this is an area that is just of such exciting interest as we all think about how do we best manage patients and what are our right data sources in our care management programs. So I'm also eager to hear ideas from the audience offline of suggestions that you all have for how to move forward in this space. So thank you, everyone.
Great, and certainly thank you. It was a tremendous presentation. So with that, I will turn it over to Melanie for closing out the call.
Thank you, Lee, and thank you, Dr. Jubilee. It was a pleasure to have both of y'all's presentation today. It provided us with a well-rounded overview and interpretation and awareness and how do we address what's facing us with the population. I wanted to bring to everyone's attention the upcoming speaking events that Dr. Jubilee and Lee Jones has coming up. As you can see, these are in front of you. If you are able to attend these events, I would highly recommend that you take the time to meet each one of them as well as participate in those speaking opportunities to be able to hear them. Again, they will be taking place in New Jersey and in Atlanta and as well in Las Vegas. Lee, can we move forward? And again, thank you to everyone that joined us for the call, for sharing your afternoon with Dr. Jubilee and to Lee Jones, and for allowing us the opportunity to provide a discussion around revolutionizing healthcare management using care coordination and analytics. If you do have additional questions, please do not hesitate to forward those in, and we will get those to Lindsay as well. So again, thank you so much for your time, and everyone have a wonderful afternoon.